Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent day in Cape Town. My name is
Just give it a minute. People are still all getting into the thing. Yeah.
They're not.
Yeah, I think we're still getting it on, eh?
We're not live yet.
I think we are, but I think it's
okay. So, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. And my name is Peter de Jong, and his name is Professor Stephen Jeffrey. It gives us great pleasure this afternoon to have Dr. Sulaiman Heylen, who's the chairman and CEO of Cape Fertility. He's a person that's often presented for the Cape Town Pelvic Floor Foundation of South Africa, and he's a person that needs no introduction, and he certainly won't get one from us. So our topic this afternoon is surgery versus IVF for your patient with endometriosis. Steve, do we have enough people? We've got lots and lots, hundreds logged on.
Nice bunch, yeah.
And Steve is going to thank you, Sulaiman. Just while we're waiting for these other people to log on, just to remind you, I promised I wouldn't say anything about FIGO, which is in October at the CTICC. But the early bird still applies. And if, in fact, you can get 25 of your or 30 of your friends together and make your colleagues come with you, you get a 25% discount, Steve. That's a lot of discount. So just think about that. So, ladies and gentlemen, without further waste of time, I'm delighted to have with us Dr. Sulaiman Heylen, surgery versus IVF for your patient with endometriosis. Thank you, Sulaiman.
Thank you, Peter, for your always very kind introduction, and thank you, Stephen, for the invitation. It's always a pleasure to be here for you and to contribute to what I think is an excellent initiative that you've got here going on a Thursday evening. So this is a long story, and this is a very old debate. And when you hear reproductive surgeons complaining about the IVF doctors that the patient comes to them with 2 or 3 failed IVFs. Now they're going to do a laparoscopy on them for severe endometriosis, and they find that the pelvis is a complete mess. And they say, oh, these IVF doctors, they mess up the whole pelvis. And then you hear the IVF specialist, on the other hand, saying, these surgeons, they're cutting away my eggs. The patient comes to me, and these patients' ovarian reserve is completely gone, and they're compromising the chance of conception for IVF. So what is now the right thing to do? Must we do surgery for our patients with endometriosis and infertility, or must we do IVF? And I have been a little bit on both sides of the, and what I've seen over the years is that things have changed, but also that the treatment that the patient receives not depends very often on what the complaints are about what they can do, but what is the interest of the doctor. So if you go somebody who's good at surgery, you will end up having a laparoscopy. If you end up somebody's going good at endocrinology, you end up having maybe some medical treatment for your endometriosis. If you end up going to a fertility clinic, you will probably end up having IVF. And a bit of a disclaimer, and for the people that are slightly younger than me, I would ask them to look up this gentleman, Professor Ivo Brosens. When I was training in the reproductive medicine, I had the immense pleasure of being his personal fellow for 1 year. And basically every Tuesday and Thursday we did laparoscopies together, he being left-handed, me being right-handed. He taught me all the steps and the beginning of laparoscopic surgery. And he is, in my opinion, one of the most brilliant minds in obstetrics and gynecology that I've ever met. So please have a look at him and see what he has contributed to our field. So if a patient comes to us, then it's not important if they've got endometriosis or whatever. It is important of what their complaint is. What is their problem? So I made, for instance, a social media post on this topic on IVF versus endometriosis. What is the best option? And immediately the question came from one of the colleagues, what is the aim of the patient? And that is basically what is important for us. Patients come to us not because they have endometriosis. They come to us because they've got pain, or because they have infertility, or because they've got other associated health issues. And there are now multiple other associated health issues with endometriosis identified. So it is our job as doctors to listen to our patients and try to help them to obtain them their objectives and not to treat the endometriosis. So I'm going to speak about how we do IVF these days. I'm going to speak about the ASHRAE guidelines on the treatment of endometriosis and infertility. I'm going to have some review articles, and then I'm going to give some final conclusions on this. But before I go there, I mean, that's just something that hit my inbox a few days ago. That's a post from the ASRM say addressing the endometriosis gap. And I thought, now let me just put it quickly in my talk. Because traditionally, we have been, in our education, we have been said that endometriosis is a disease, and these are American data from white women, and it is not very common in African women and in other race groups. And there's a problem that endometriosis is underdiagnosed in Black women because that historical bias is the typical disease of the type A affluent white woman. And this contributes to the delay in the diagnosis for endometriosis for African women, for Black women. And this is an American article, but I think it's also very valid in the South African context, that the diagnosis is very often not made properly. There's a delay in the diagnosis, and we say, okay, the pain and the infertility are caused by infections or by fibroids and not by endometriosis. And yes, when I was trained for endometriosis for the gynecologist, it was taught that endometriosis is a disease of white affluent women. And that has got consequences because it means that Black women have got less access to good quality, minimal invasive surgery. They've got a high rate of inappropriate surgery like oophorectomy and hysterectomy, and that they don't have access to high volume, minimal invasive surgeons that do all the time endometriosis surgery. And that article also said there are strategies that we have to follow for to address these imbalances. That is both an awareness, but also to revise our training, our textbooks, our training for our young doctors and our registrars and our fellows, and also make sure that our referral centers for endometriosis are more aware of that. And these are the references about that. So, as I said, if a patient comes for treatment, then we've got, as doctors, we've got options of medical treatment, we've got options of assisted reproduction, and we've got the option of surgical treatment for a patient with endometriosis. So the medical treatment, we can go to our birth control pills, we can go to Visan, we can go to our Mirenas, we can go to a GnRH agonist, we've got our IVF and IUI, and then we've got our laparoscopic surgery. And these are basically the three pillars of treatment that we have for our patients with endometriosis. So what must we do? Depends on what the patient is complaining of. So has the patient got associated pain? Yes or no? What is the duration of the infertility? Especially if it's longer than 2 years, it becomes a more serious issue. What is the female age? Is the patient young, or if she's above the age of 35? What is her ovarian reserve? We must do a good antral follicle count and a good AMH. Is there associated other fertility problems like male infertility? What is the insurance? Because most medical aids do not pay for IVF, but they do pay for laparoscopic surgery. What is the local availability of the procedure, especially in low income settings that can be important? What is the experience of the medical team? Is there any previous surgery done? Because many women with endometriosis have one or more surgeries done before they come to the referral center. And most importantly, the biggest question is, what is the best chance for this patient to be pregnant as soon as possible? Because if she's got infertility, that's what she wants. She wants a baby. So it all started long time ago in 1997 with the ENDOCAN study. And the ENDOCAN study was the first prospective randomized study that showed that surgery for endometriosis is beneficial. And from there onwards, we have been operating women for endometriosis. However, since 1997, we obviously IVF, we did a lot of IVF, but IVF has changed a lot. What is now different in IVF than it used to be 10 years ago, 15 years ago? With the current stimulation protocols, ovarian hyperstimulation syndrome, it hardly ever exists anymore. So that's something, a risk that we can say that doesn't exist anymore. Our freezing is now so good that we sometimes even speak about freeze all cycles, but a frozen embryo transfer has the same or even better success rate than fresh embryo transfers with the current technology. We do pre-implantation genetic testing of embryos routine-wise. It's a standard technique. It's something that's done every day without the risks that were previously described. It's now standardized that we can do without any problems. Frozen embryo transfers have become a lot easier. We do frozen embryo transfers in the what we call the modified natural cycle. So basically, we just stick it in at the right time of the cycle without using too much medication. We do an ultrasound-guided embryo transfer. We don't transfer multiple embryos anymore. In the majority of the cases, we transfer one embryo. So if a patient comes from Sulaiman and he's got twins, and you can say, "Hi, Sulaiman, why did you transfer 2 embryos?" In the majority of the cases, we should transfer only 1 embryo. And then we speak about a 1 cycle and done. That means that 1 IVF cycle should be sufficient for a patient to have 1 baby or even more, because we can obtain multiple embryos from 1 cycle. So what are the chances of conception? What is the success rate with IVF? We all know that this is an age-dependent thing. So in the ideal situation, you can have pregnancy rates of 50%, and I speak now always about singleton embryo transfer. What case is that? For instance, in cases of egg donation or in cases of PGTA, where you transfer 1 euploid embryo. For women under the age of 35, so for typical patients that come to the fertility clinic with blocked fallopian tubes or male fertility, that under the age of 35, you can have a success rate of 40 to 50%, and it drops with age. So I always say to the patients, if they ask me what is the success rate of IVF, then I say, it's good when you're young, it drops slowly until the age of 35. At the age of 35, after that, it drops with about 5% per year. And then we see that at the age of 45, we are looking at close to 0. So fertility treatment, IVF at the age of 45 is not really successful anymore. And women above the age of 43 should strongly consider doing egg donation if they have infertility. These are 2 articles that I would like to mention that have set really the cat among the pigeons in the fertility world. So the first article was an article where they did 3 consecutive embryo transfers with a PGTA-tested embryo, with an euploid embryo. And that was about 5,000 patients. And the second one is a review article with the same thing, with PGTA-tested embryos with up to 5 consecutive cycles. And what they've seen in these cycles in the first paper was that the success rate, the live birth rate, remains high even after multiple failed embryo transfer. That means if you transfer an embryo and it doesn't work, and you transfer again an embryo and it doesn't work, if you transfer it the 3rd time, you still have got exactly the same chance of success. It works. It doesn't sound right, but it is what it is. And the second paper that was published last year even showed it better. Up to 5 cycles, if you have a PGTA-tested embryo, if you've got an embryo that's euploid, and you exclude anatomical reasons, for instance, there is no fibroid or a polyp inside the uterus or no congenital abnormality of the uterus, then the success rate stays the same. That means if you transfer 1 embryo, you've got a success rate genetically tested of 50%. If it doesn't work, you do it again, your success rate is 50%. If you do it again, your success rate remains 50%. Even the 5th time, the success rate remains 50%. So these 2 studies showed that And both studies were similar. The first one said after 3 successive embryo transfers, you still have got a very high chance of success. And it means that recurrent implantation failure, I mean, it's something that we doctors, we fertility doctors, we use as we transfer a few embryos and the embryos look healthy, but the woman doesn't get pregnant after a few embryo transfers. So recurrent implantation failure, which is not the same as recurrent pregnancy loss, although, I mean, people have mixed these. So the conclusion of these 2 articles was that recurrent implantation failure is very rare. And in the second article, they saw that even after 5 embryo transfers, 98% of all women is pregnant. Only 2% of the women is not pregnant, and that recurrent implantation failure should only be considered if you have transferred 5 genetically tested embryos. I think that's a bit much, but it says that if you do IVF and it doesn't work, then you must just carry on with it. Because sometimes we think that carrying on with doing the same thing and you do it again and expecting a different result, it's stupid, but for IVF, it's not. And it is important to understand, and when a patient comes for IVF, to explain the concept of cumulative pregnancy rates. So if we go back to the articles that I just mentioned, in both articles, with genetically tested embryos, they have got a live birth rate of just over 50%. That means if you do an embryo transfer and it doesn't work, if you come back again, 50% of all the women are going to be pregnant. That after 2 cycles, 75% is going to be pregnant. After 3 cycles, 87.5%. And after 5 cycles, more than 95% is going to be pregnant. Now you say, Sulaiman, that's not realistic. This is an ideal situation. It does exist. It happens in 2 cases. In our cases of egg donation, where you have eggs from young women, or in our cases with PGT-A, then we can realistically have this type of success rate with a single embryo transfer. But yes, for most IVF patients, it's a little bit less. So you've got a 40% chance of success, still good for a typically young patient who comes for dual factor infertility or male factor infertility. After 5 cycles, we still have got a more than a 90% cumulative chance of success. Sulaiman, that's not realistic. For 30% after 5 cycles, you still have got an 80% cumulative chance of success. And even if the success rate is 20%, that's maybe our typical patient who is closing into to 40 with not such a good egg quality anymore, you still see that after 5 transfers, we've got 2 out of 3 women are pregnant. So we are speaking here about not IVF cycles, but we are speaking here about embryo transfers. And every time 1 embryo is transferred, because we hope to have from 1 IVF cycle more than 1 embryo, that we can freeze the remaining embryos. We transfer 1 at a time, and subsequently in the next cycle, in the natural cycle, we transfer again another embryo. So if you put all these curves together, and see, in an ideal situation, see if you got 50% success rate, let's say the total chance of success is after 5 cycles is 97%. So if you go back to the article that was that I just presented of McGill, it's less. Huh? So in reality, you saw even a higher success rate than this theoretical chance of success. So this is realistically obtainable in cases of PGT-A tested embryos. So I was just speaking to Paul, my colleague here at Fertility Clinic. So I had a patient, I did IVF. So it's a patient with recurrent implantation failure, had multiple failed IVF cycles, and it was attributed to her egg factor, and she's a bit older. So yes, patients now in her early 40s. So we said we have to do egg donation. We did egg donation because of the history of recurrent implantation failure, and she's fine. She had hysteroscopy and she's healthy. We decided to do egg donation with PGT-A. So we did it. So I did transfer an embryo. It didn't work. I did transfer again another embryo in a subsequent cycle. It didn't work. I did it again the 3rd time. It didn't work. So she comes back to me. We still have got several PGT-A tested embryos. We've got multiple euploid embryos. She asked me, can we transfer 2 embryos, please? I said, no, it's maybe not a good idea. But anyway, at the end we did. Scan result this morning, twins. So yes, that's how it goes. So we must sometimes just persist in the insanity and in the madness to have a good result. And we all try to obtain it from one IVF cycle. So modern IVF means one egg retrieval with good freezing, vitrification, with sometimes PGTA, and we do multiple frozen embryo transfers in the natural cycle, which is not invasive for the patient, and we speak not about pregnancy rates, but about cumulative pregnancy rates. But that is what Sulaiman says. What does ESHRE say? What are the ESHRE guidelines of endometriosis? So if you look at the ESHRE guidelines and you look at it, then you can take out the statistics, what they recommend. And you see that the IVF success rates per embryo transfer are slightly better in early stages of endometriosis, 30 to 40%, than in more advanced stages of endometriosis. And that it also depends on the prognosis of the patient. So the EFI, the endometriosis fertility index, I'm going to speak about it a little bit later. So that means patients with a good prognosis so with not severe endometriosis, and who are younger, they've got an up to 50% chance of spontaneous conception. What is the recurrence of endometriosis? It's within 5 years, 30%, within 10 years, 50% after endometriosis surgery. These are not my data. That comes from the ESHRE guidelines. In the past, we said also endometriosis, if you're pregnant, it doesn't give an increased risk of pregnancy, but more and more data says yes, there's more risk of miscarriage, ectopic pregnancy, and also preterm birth and preeclampsia. So this endocrine study that I mentioned already showed that after a follow-up of 9 months for the removal of minimal and mild endometriosis, you've got a 32% total cumulative pregnancy rate after 9 months follow-up. But they compared it to diagnostic laparoscopy. That means you do a laparoscopy, you see the endometriosis, but you do not treat it. And in this group, we also had, obviously, they also had pregnancies and had about half the amount of pregnancy. So it means that after 9 months of follow-up, they could increase the chance of success from about 16 to 32%. If you look at all the studies that have been published together, so this is the 97, is the endocrine study with 2 other studies, 2 smaller studies. They were not significant, but they were seeing if you treat by laparoscopy, minimal and mild endometriosis, you can maybe nearly double their chance of natural conception. So what does ESHRE say if surgery for an IVF versus surgery for endometriosis associated infertility? Surgery is best for early stages endometriosis. IVF is better for moderate to severe endometriosis. The success rate, if you got a good prognosis with early stage endometriosis, can be up to 50% with a maximum follow-up, with a follow-up of 2 years. For IVF, that's what we mentioned. For early stages endometriosis, got a little bit of better success rate for later stages of endometriosis. Surgery does have an effect on your ovarian reserve, IVF not. The recurrence risk we've spoken about, the IVF has got no impact on the recurrence. The same pregnancy risks do exist in cases of endometriosis treated with surgery or with infertility. So yes, you've got increased risk of miscarriage, ectopic pregnancy, and preterm birth. And the live birth rate is generally higher with IVF than with surgery. So what do they say? What are their guidelines? Operative laparoscopy could be offered as a treatment option for endometriosis associated infertility for your early stages, year 1 and 2, which is a weak recommendation, because it's not too many patients that you get pregnant. You get some of them pregnant, but the difference with natural conception not that high. So if you got endometrioma associated infertility, the clinicians, you can consider doing surgery for that, as it might increase their chance of natural pregnancy, but there are no good data, there are no good comparative studies. So you've got no prospective randomized studies to show that. There is no compelling evidence that operative laparoscopy for deep endometriosis improves fertility. Yes, you can do that as an option, but it's only a weak recommendation. And the decision to perform surgery, according to ASHRAE, should be guided by other things: pain symptoms, the age of the patients, the personal patient preferences, previous surgery, or the ovarian reserve. And they say that the endometriosis fertility index is a good tool for that. So I will speak about endometriosis fertility index a little bit later. So what are the conclusions of ASHRAE? For mild stages, you can do surgery. For moderate to severe stages, IVF is the preferred option. Now I'm speaking about fertility. I'm not speaking about pain. I'm speaking about fertility. And the endometriosis fertility index helps you to guide. So what is the endometriosis fertility index? I mean, I didn't know. I mean, I've used it a few times. It's a good tool, actually. But if you look at it from an intuitive point of view, it's what we are all doing. All fertility doctors, all endometriosis doctors are doing all the time with our patients without scoring it objectively. So it's a scoring system used to predict the spontaneous chance of conception in patients with endometriosis. So we look at key factors like the patient age, what we do, how long have we tried to conceive, how bad is the endometriosis, especially also what is the function, what is the relationship between the fallopian tubes and the ovary, and what are the post-surgical findings. And then we make a scoring system going from 0 to 10. And if the score is above 5, then we say, oh, this is a good prognostic patient. So if a patient has got a score from 9 to 10, that means she's got a very good chance of success. For lower scores, 5 to 10, she's got a moderate chance of pregnancy, probably around 25%. If the score is under 5, then she's got a low chance of conceiving spontaneously, and then it's a good idea to refer her to IVF as soon as possible. So for patients with a good score above 5, you can say, okay, you can try to wait for spontaneous conception. And this was studied by this study, the EndoQual study. It was published in 2021. So it's a good study, because they did 234 patients with endometriosis. So it's always difficult to do surgery and then look at the outcome. And it is even more difficult to do surgery and then look at fertility outcome because it requires a long follow-up. And then if you can do 234 patients, I think that's very good that you can do a study like that. And then even better, they didn't look at pregnancy rates, but they looked at cumulative pregnancy rates. So this is a very, very high quality study. And what were the key findings of the study? So yes, and they specifically studied that endometriosis fertility index. The endometriosis fertility index is an important factor. So with a low endometriosis fertility index, you've got low chance of success. If it's more than 5, you've got a higher spontaneous chance of conception, and less patients need IVF. So they say this is good, and we can use the fertility index score because it's a good predictor to determine if your patient is going to conceive spontaneously or if you need to refer them for IVF. So how does it work basically? So you look at what we call the least functional score after conclusion at the surgery. You do your surgery, and then you look at basically your interaction between the fallopian tubes and the ovaries, and you say, if is it good, is it not so good, and you score it from 0 to 4, and you write it down. Plus, you look at all the other factors, at the age, the years of infertility, has she been pregnant before, and then you also look at the American Fertility Society, the ASRM score of infertility. You all add it together in a score from 0 to 10, and then you can use the endometriosis fertility index. So if you go back to the previous slide, they say that it's indeed a good predictor, and if you've got a good prognosis, then you can wait. And you can wait for spontaneous conception. But can you? Because if you look at the article, then you see that the spontaneous conception rate in older patients, the good and bad prognosticator was less. It was only 25% with an average follow-up of 14 months. So that's not pretty good. It's okay, but it's not pretty good. So what does the literature say? So I asked my assistant. It's called ChatGPT and ResearchGPT to do a review on all the review articles that have been published in the last 2 years on endometriosis and reproductive surgery and IVF, and to summarize it for me. And I found quite a lot of beautiful articles for that. I would like just to mention them to you, and then we can draw our conclusions from them. So this article
Sulaiman,
speaks
sorry,
about-
before you
Yeah.
continue with that, when we were taught a number of years ago to do some of this endometriosis stuff, the tubes still being patent in endometriosis, does that have any impact on the fertility? Because I remember people sort of occluding the tubes or blocking the tubes or removing tubes. Is that
Yeah, you speak about hydrosalpinx, huh? So
Yeah.
if a patient has got a hydrosalpinx, we know that if a patient's got a hydrosalpinx, it has got an effect on the implantation rate, because you can just see it very simple, very easy. The fluid inside the fallopian tube leaks back inside the uterine cavity and kills the embryos. That's
Okay.
why if you do IVF and the patient's got hydrosalpinx, not blocked fallopian tubes, but it's got hydrosalpinx, then you have to block the fallopian tube. So you have to clip them, or you do a salpingectomy before you do your IVF cycle. You have to obviously be careful that you don't interfere with the ovarian vascularization before you do that. But yes, that's it.
Yeah.
Now, it's only for the hydrosalpinx that are big. So we are becoming very good at ultrasound these days. So the consensus now, we have to do it with the hydrosalpinx, which is visible on ultrasound, on transvaginal ultrasound.
Okay. Thank you.
Yeah. Good. So this article studies the review article published last year, endometriosis and in vitro fertilization. So endometriosis affects the ovarian reserve, but does not significantly impact live birth rates in IVF. And routine surgery for ovarian endometriomas is not recommended. So that's, I think, a good point that we have to remember here. Routine surgery for ovarian endometriomas is not recommended unless for symptoms. And let's speak about frozen embryo transfer might be beneficial. This article, the impact of surgery for endometriosis on the outcomes of in vitro fertilization. So they look at this on deep endometriosis. They say the available data are not sufficient to recommend surgical excision of deep endometriosis for asymptomatic patients. So if a patient's got a nodule sitting over there and you just find it and she's got infertility, there's no reason to cut that nodule out. There is no proven benefit of that. Then it appears unlikely that surgical treatment of superficial endometriosis can improve IVF ICSI outcomes. So if a patient going to do IVF and she's got endometriosis, don't cut. Surgical treatment of endometriomas does not enhance IVF ICSI outcomes. In contrast, excision of ovarian endometriosis can reduce the ovarian reserve, especially in cases of bilateral endometriomas. So it was, I think, also discussed by Igno a few months ago. So surgery for endometriosis will not be beneficial for your IVF, and it can affect your ovarian reserve. So you can reduce the amount of eggs, and if it reduces the amount of eggs, it can have an effect on your cumulative chance of conception because you've got less blastocysts to transfer. So I've got an example. I'm going to do an egg retrieval on a patient tomorrow. It's surgery done by a gynecologist for severe endometriosis. She had a recurrence of endometriosis. The gynecologist referred the patient to an expert, a high volume endometriosis surgery. A repeat surgery was done. 2 years later, the patient comes to see me, still not pregnant. She has got an endometrioma of 5 centimeters. I don't care. We are going to do, she's booked for her egg retrieval tomorrow. She's got an excellent ovarian response. So I expect to have at least 10 eggs tomorrow, and her chance of success will be the same as for anybody else with IVF. So this article, impact of endometriosis surgery on in vitro fertilization and ICSI outcomes, a systematic review and meta-analysis. So what are the conclusions of that article? No clear benefit of surgery before IVF. Potential negative impact of surgery. So when studies with high risk where he excluded the live birth rate per cycle was lower in patients who had surgery before IVF. So I think that's a very important thing to understand here. So I'm going to repeat that, that the live birth rate per cycle was lower in patients who had surgery before IVF. And then, yes, that's what all these review articles said. You must individualize it, and you must have more research needed, and you must discuss it with your colleagues. And I think that's very important. The multidisciplinary centers that we say, if a patient comes with for infertility and endometriosis, that you make sure that they've got a good IVF doctor, a good surgeon, and a good endocrinologist available. This article titled IVF Stimulation Protocols and Outcomes in Women with Endometriosis. What were the conclusions of the article? IVF is preferred over surgery for endometriosis-related infertility as it bypasses the pelvic problems and it bypasses the pelvic inflammation. Surgery may be beneficial in certain selected cases for young patients, yes, for patients with pain, obviously, for spontaneous and you can have a spontaneous conception in up to 2 years post-surgery. Surgical removal of endometriomas, again, can potentially lower the chance of success in IVF, making first-line IVF a better option. You've got an endometrioma and it's a fertility patient, IVF is your first-line treatment, especially for women with a low ovarian reserve, but also with women with deep infiltrating endometriosis. IVF is your first approach. And then again, a personalized approach is necessary. Then, oocyte quality in patients with ovarian endometriosis undergoing IVF, ICSI, a systematic review and meta-analysis, oocyte quality. So we always thought, and I was always under the impression, and 10, 20 years ago, we say that IVF in women with endometriosis doesn't work too well. But here they say IVF successes are not significantly impacted by ovarian endometriomas in terms of fertilization, blastocyst formation rate, and cancellation rate, suggesting that oocyte quality remains the same in patients with endometriosis. However, women with ovarian endometriomas have a lower number of total eggs. Say that not the quality, but the quantity of the eggs is reduced. Another conclusion of this article is surgery is not necessary before IVF, as the endometriomas does not seem to compromise embryo development or implantation, and surgery can reduce further the ovarian reserve. That's what I'm going to do with that patient from tomorrow. She's got endometrioma. It's fine, not a problem. And then again, same as what I say after every review article. A personal approach is essential, considering ovarian reserve and patient age, but IVF can be a viable first-line option, and surgery is only be reserved for selected cases. So, I think this is very important for us, for South Africans. Endometriosis managed in low-income and middle-income countries, a critical review. This article published this year. IVF is indeed the best option for a woman to be pregnant, but it's not always possible to have that, and therefore laparoscopic surgery remains the most commonly used treatment for endometriosis related to infertility in low and middle income countries. Another conclusion of this article was surgery before IVF does not improve pregnancy rates, the same conclusion. Cystectomy, ovarian cystectomy can negatively impact ovarian reserve, same conclusion again. But in countries like South Africa with limited access to IVF, we have to individualize our approach, and we can offer laparoscopic surgery with especially make sure that we do fertility sparing and very careful surgery. When IVF is an option, however, a direct IVF approach may be preferable to avoid ovarian damage from unnecessary surgery. So what about the endometrium? The endometrial receptivity in women with endometriosis. This article, published last year, says that the available data suggests that endometriosis does not have an impact on the endometrial receptivity, and that pre-treatment for endometriosis with GnRH or with progesterone or diagnosis does not help. It does not improve implantation rates. And then there is limited evidence that surgical treatment of endometriosis improves implantation rates. Therefore, again, same story, surgery should not be performed to improve outcomes of IVF. Then this article, also published last year, combines surgery and IVF in endometriosis-related infertility, when and why. Conclusion of the article. IVF is the preferred first-line treatment when bilateral endometriomas. So please, I say that again, IVF is the first-line treatment in patients with bilateral endometriomas, previous pelvic surgery, obviously male factor infertility, and advanced maternal age, I think is obvious. Surgery may benefit younger women with pain and infertility. Repeat surgery should be avoided. I'm going to repeat that. Repeat surgery should be avoided. Surgery does not improve IVF outcomes. Again, the same conclusion of this article. Ovarian surgery may lower the chances of IVF success. And then in asymptomatic cases, first-line IVF without surgery is recommended. So I highlighted these two from the conclusion of that article. Another article published this year, reproductive outcomes in infertile women with endometriosis undergoing assisted reproductive technology. So recent studies, including euploid, PGTA-tested embryo transfers, and egg donation, so we come back to our ideal cases, suggest that endometriosis may have less impact on IVF success rates than what we thought in the past. So in patients with endometriosis, IVF seems to have very similar success rate than in patients with tubal infertility or male infertility. Another conclusion of this article is surgery and hormonal suppression before IVF does not improve outcomes. Oocyte quantity may decrease in women with endometriomas, but oocyte quality, embryo development, and pregnancy rates remain the same. IVF-assisted reproduction remains effective in women with endometriosis. So did Sulaiman say that we should not do surgery for endometriosis? So now please don't go or say to everybody, Sulaiman said we should not do surgery, never for patients with endometriosis. There are indeed still indications for symptomatic patients, for young patients, for patients with a good ovarian reserve. If IVF is not available in low and middle income countries, it can be for the insurance reasons, because in South Africa, medical aids do cover very often for laparoscopy, but not for IVF. If there is a compromise of organ function, for instance, if there is an obstruction of the ureter or bowel obstruction, for technical reasons, for instance, I did a laparoscopy on a patient a few months ago, where she had an ovary which was attached to the pelvic side wall. It's very difficult to attach to your transvaginal egg aspiration for the patient. So you release that ovary, you put it back in the pouch of Douglas. And then, as Stephen just asked, in cases of hydrosalpinx, to remove the fallopian tube or to clip the fallopian tube. But the conclusion is very clear. IVF is a first-line treatment in most cases of infertility and endometriosis. And the success rate of IVF is not affected by endometriosis. So IVF is an as successful treatment for endometriosis as for other cases of infertility. And we must be very careful not to reduce the chance of success by cutting too many eggs away. Or I can be even more blunt about the whole situation. Surgery has a 25 to 50% cumulative chance of conception rate with an average follow-up between 12 and 24 months, according to the studies. However, IVF has a 25 to 50% cumulative chance of conception with an average follow-up of 1 to 2 months. Thank you.
Great. Thanks so much, Sulaiman. That was wonderful. And just thinking, it seems that less and less surgery is going to be done for endometriosis. Are you finding that you're doing a lot less endometriosis surgery now that we understand where it sort of fitting in with patients with infertility? Are you
Yeah, absolutely. And I think that's a very very good question that you are asking. I mean, when I was young, and I'm still young, huh? But when I was a little bit younger, then the laparoscopy was the place, I mean, that was done by the reproductive surgeons. So if you 25 years ago, even the reproductive surgeons, they were doing hysterectomies because the average gynecologist and the average oncologist, they didn't do laparoscopy, they did all the oncology. So the laparoscopy was always done by the fertility doctors. And now we find just the opposite thing, that we as fertility doctors, we do less and less laparoscopy. We're doing more and more hysteroscopy. So I do not 10 hysteroscopies per week or something like that. But in the past, I used to have an operation list where I did 5 laparoscopies on a day on patients for endometriosis and adhesiolysis and ovarian drilling for polycystic ovarian syndrome. But now we do very little surgery for endometriosis and infertility, and we do more and more IVF for these patients. So yes, the amount of surgery that we do for endometriosis is now not less, and we do more IVF.
Thank you, Sulaiman. There's another question here. Do you find that the average cost of IVF is coming down, given the natural cycles and the recovery of several eggs in the initial cycle, in the initial recovery phase?
Well, yes, the cost of IVF is not coming down for normal IVF, but if you look at the cumulative cost of IVF, it's certainly coming down, because in the past we did IVF, and we transferred 2 or 3 embryos on cycle day 3, and if it didn't work, we did another IVF cycle, and if it didn't work, and we had to start again with the stimulation. These days we go for day 5. Our freezing is so good that the subsequent cycle, we always say we've got the same success rate, we've got no injections, we've got no operation, and it is a fraction of the cost of a fresh IVF cycle. So yes, frozen embryo transfers definitely reduce the chance, make the IVF cheaper.
Thank you.
Yes.
Here's another one from Oscar Shimangi.
Hi,
Please,
Oscar.
please, you won't be so happy when you see what he's asking you. He says, can you do a comment on adenomyosis, please?
Oh, no. Yeah, that's because Oscar, me and Peter and we were just talking about it before the presentation. Adenomyosis is such a difficult subject, and there's still so much research necessary for adenomyosis. And we see now more and more adenomyosis, and because our ultrasound machines are going so much better, every time that we get a new ultrasound machine, we diagnose a lot more people with adenomyosis. So it is very difficult to say what to do with a patient with adenomyosis. Surgical approach for adenomyosis is controversial unless this is a patient with a focal adenomyosis, with an adenomyoma, or a patient where the adenomyosis is protruding or close to the endometrium. So that means in the 1/3 of the myometrium that's close to the endometrium. Then hysteroscopic approach is possible. And then, yes, sometimes there is some evidence that downregulation, 3 months of downregulation for adenomyosis might be beneficial before an embryo transfer, in contrast with endometriosis. And that's maybe where the confusion comes from, because in the past, it was recommended to do downregulation in patients with endometriosis, because I think many of these patients did not have endometriosis, but did have adenomyosis, and therefore it was that recommendation came. But I cannot comment too much on adenomyosis because it's a very, very difficult subject, and we still don't know too much about adenomyosis.
Yeah.
Can I just add something here? Sorry, Peter.
No, after you,
topic. Yeah.
on adenomyosis, yeah.
Yeah.
Sorry.
Speech, yeah.
No, I was saying that Rafiq Bakar, who does a lot of surgery and also has a connection in India, he showed me some work recently of how many Indian surgeons, laparoscopic surgeons, are doing adenomyosis. And I'd like to see at FIGO, there are a few talks on the subject. I'd be very interested to see what the people are doing and how they're doing it. Thank you.
There is done a lot of surgery. surgery on that for adenomyosis, and it's done a lot of hysteroscopic surgery, and it's done a lot of laparoscopic surgery. I think we must look a little bit at the data and what the outcome is. And as I said from before, it's a very difficult thing to study, because if you do study for IVF, you can quickly look at outcome, but if you look at surgery and outcome, it's a lot more difficult. And then if you look at surgery and outcome for infertility, you need to have a long follow-up. So these are very difficult things to study.
Yeah. And so a lot of the guys were doing, I went to some workshops in India, and they were doing this wedge resection for adenomyosis. And,
Wedge resection.
yeah, so they do like, I actually saw how they do it. They kind of wedge it out and they suture it together. I mean, it's actually a very big operation in India. I don't know if they're doing it anywhere else. Is there any evidence for it? Is there anyone doing it who's really sort of doing it?
Well, I've done it a few times. So to do like we do an uterine reduction, to cut away as much as possible of the uterus, and then do a wedge resection, then close it as a myoma. I do the double flap. You flap it over each other, and then close the uterus like that. And some people do that to look at what the reproductive outcome is. It's difficult to say. I think it's more evidence to say that it might be beneficial for pain, but at the reproductive outcome, there is no good data on that to say that it is really beneficial for that.
Erwin is asking us here, he's saying great talk. Young women often fear long-term use of COCs or Vazan that may help her pain, but concerned it may decrease their chance of a pregnancy later. There's no evidence for that, is there? I mean,
so if a patient is 16 years old and we suspect based on the history that she might have endometriosis, and put her on the birth control pill for dysmenorrhea or pelvic pain, and it helps. And she stays on the birth control pill for 10 or 15 years until she wants a baby. There is no doubt about it, that her chance of having a baby will be better than if she has not been on birth control pills.
that's good. That's good news.
Yeah, we had a talk the other day about Toby de Villiers, and it's also controversial, should you use the pill or not in endometriosis because of the estrogen. And incidentally, he's going to be talking on the 8th of May, Toby de Villiers, on menopausal hormonal therapy and testosterone.
Well,
So,
I don't think it's controversial to use birth control pills, because yes, you've got the estrogen, but for symptom control, all the studies of Vercellini show quite clear that it is a very effective treatment for dysmenorrhea in patients with endometriosis.
how often do you try cycling in these women? In other words, do you have knock out the placebos, or do you just let them menstruate every month?
Every third month.
Every 5 months?
Every third month.
Oh, every third month. Okay,
Yes,
yeah.
that's standard treatment for women with endometriosis. So we don't let them have a period every month.
Yeah,
that's good.
because Steve, you see, periods, menstruation, in fact, is a very inflammatory condition.
Yeah.
And here's an anonymous person that says, is there a role for routine AMH prior to surgery, and can it be used to guide the management plan? Sulaiman?
Yes, absolutely. Thank you for the question. Yes. So if you've got a patient you don't know what to do. So the patient, it comes to you, she's got, for instance, an endometrioma. She's been trying to conceive for 2 years. She's got pain, but it's manageable. It's not too bad. And she wants to have a baby also. Her AMH is 0.5 or her AMH is 4. It's a big difference. So it's got a very good AMH. You say, okay, let's do my surgery, because if you drop the AMH a little bit, that's fine, because she still has got an excellent ovarian reserve. But if the AMH is already a little bit borderline, you can say, oh, let's not going to cut away more eggs. So yes, it's definitely something that's going to help you to guide if you have to do surgery, yes or no. So your ovarian reserve is one of the crucial factors, in combination with pain, and in combination with the duration of the fertility, and in combination with the age of the patients, if you're going to do surgery, yes or no.
Right. Excellent. Well, thanks, Sulaiman. It's been again a wonderful talk. Thanks for giving us such a great up-to-date review of the evidence as well. I think there's been some great take-homes here in terms of the fact that, you know, we need to be careful, those of us who are the occasional laparoscopic surgeon, and, you know, we find something with someone with endometriosis. You know, I think it's very important for us to do less rather than more. You know, most like when you do a breach, you know, rather do nothing, or just stand there, or, you know, just
Breach.
less is more, you know.
No,
like,
we do a Caesar for a breach now.
yeah, well, I mean, when you used to do vaginal breech delivery, you used to just stand there, let the breech come out. Yeah, the less is more, you know.
Yeah, I know.
And in this kind of thing, it's very much the same thing. You know?
Absolutely,
Yeah.
Steve.
So yeah, well, I mean, old days. But thanks
Well-
so much, and it was a wonderful review, and you know, I think we've got a great idea as to, you know, what to do. It's just worries me that you know, we're going to start losing the skills for some really good endometriosis surgery with
Yeah,
guys like
but that,
less and less, you know. It's,
No,
yeah.
yeah,
you still
that's
do
why,
lots of endometriosis surgery. There's ICNU in them. So I don't
yeah,
think
But
it's,
about the next
that's why it
generation.
should go to centers, to people who only do a lot of them.
yeah.
And then so, but if the to what they call the high volume surgeons. So I'm not saying there is no indication for surgery, but yes, that's true. We're doing less. I mean, that was the question. We're doing less and less surgery for endometriosis and infertility.
Yeah, I'm just worried about the training. You know, if you know, the Sulaiman's generation is doing less, you know, what about the next guys who aren't getting exposed to as much?
That's true,
You
Steve.
know, to worry. Anyway, but thanks so much.
Steve,
Yeah.
just to remind you, and Sulaiman, once again, on my behalf, I'd like to thank the Pelvic Floor Foundation for the sponsorship this afternoon. But the 1st of May, being a public holiday, there is no presentation. On the 8th of May, we've got Toby de Villiers, and he's on menopausal therapy. So, excuse me, we look forward to that. And then a special thank you for your presentation this afternoon, Sulaiman. It's been wonderful. And as Steve says, lots of take-home messages. So, ladies and gentlemen, I'd like to wrap up then. Wonderful hearing, Sulaiman.
Thanks, Peter. Thanks, Stephen.
I'd like to
Yes.
thank Chris.
Mm.
Chris is our technician. And again, a special thank you to Steve for the use of his minibar. Minibar's gotten a bit bigger recently, I see, Steve. But that's really kind of you to share it with us.
Sure.
And Sulaiman, you've said very kindly that you're going to be able to present in the second half of this year. We look greatly forward to that. It's going to be wonderful to hear you again. And we're going to be hearing about, what did you say? Hysteroscopic resection.
Hysteroscopic tissue removal systems.
Hysteroscopic removal systems. Yeah.
Yeah.
That's going to be wonderful as
Yeah, we
well.
look forward to that. Yeah, can't wait. Right, well,
Okay.
thanks so much, and safe home, everybody, and we'll see you again in 2 weeks' time.
Inshallah. All the
Okay.
very best then, Sulaiman. All the best then.
Thank you.
Alhamdulillah.
Thank you.
Bye.